So, Ajita, just let me know when to start. I think it's already 1 minute to go. Yes.
Can I share the screen in the meantime, Ajita?
Yes, sir.
Let us just. Is it visible?
Yes. Make it full screen.
I'm just making and trying to run it. Is it moving now?
Yes, it's moving.
That's fine. Okay, good. Otherwise, this becomes a challenge at the last minute.
Yeah.
Good evening, Satya sir. Good evening, Gaurav sir, and everyone. Good evening.
Good evening,
Hi,
Ankit.
good evening, Ankit.
Good evening, everyone.
Good evening, Vaibhav. Good evening, everyone.
Good evening, everyone.
Sir, I think we can start
Start?
it.
Okay. Yeah,
Yeah.
great.
Sir, you can give the introductory remarks, and then
Yeah, yeah.
probably by the time Sir starts,
Sure,
people
sure,
will
sure.
join.
Hi, good evening, everyone. This is Dr. Satya Yadav. I'm chairperson for PHO chapter of IAP. So it's pleasure to welcome you all to another webinar by PHO chapter of IAP in collaboration with ECHO India. And as usual, we have interesting topics lined up. And today's topic is sickle cell disease, an update on sickle cell disease. And this is an important topic, as you know, that thalassemia takes the cake, but sickle is a far bigger problem. And it is affecting the people who are poor and they don't live in the mainstream cities. They live in the tribal areas where health services are lacking completely. So they are not reaching the main health system, and so they are undertreated, and that's where the problem is. So anyway, those are the challenges of our country, but it's a big problem, and we need to focus on it and make treatment available to all. So today we have a famous speaker who has done a lot of sickle work in India. That's Dr. Gaurav Kharia. So Dr. Kharia is director for Center for Bone Marrow and Cell Therapy at Indraprastha Apollo Hospital, Delhi. And he has done tremendous work in sickle cell disease. And today he will be speaking on changing paradigm in conditioning chemotherapy for sickle cell disease, Indian experience. So Gaurav, it's a pleasure to have you here today. So please start your deliberations. Thank you.
Good evening, sir, and thank you for this very, very generous introduction. And thank you, the entire scientific committee, for giving me this opportunity on a very pertinent month or pertinent time of the year. As we know that June is celebrated as Sickle Cell Month, and sickle cell disease just around the corner, June 19th. So this is very pertinent, although this advocacy, as sir has highlighted, has to be a continuous process, but such months and such days are dedicated to do some more concentric efforts around the advocacy for such specific diseases. So I'll be talking more about the changing paradigms in conditioning chemotherapy, and this is basically I would say, a personal experience of what we have learned, what challenges we have faced, and what modifications we have done to overcome these challenges. So a quick overview of today's presentation. So we'll briefly look at the histories of, I mean, personally, whenever I look into any particular thing, history is very, very intriguing. So I always try and focus a little bit on the history, what contributions people have made. Subsequently, we look at the global burden of the disease. How does that landscape look like? Why do we still need to talk about sickle cell disease and the curative options for sickle cell disease, and more so the preventive strategies for sickle cell disease? What is the WHO forecast? Pathophysiology, therapeutic options, care and cure. Then, after this sort of brief discussion about the disease, we'll move on to transplant. So how transplant evolved for sickle cell disease, what are the historical perspectives, how our other colleagues across the world have tried to evolve the transplant conditioning strategies for sickle cell disease, and what lessons we have learned as we have moved ahead in transplants for sickle cell disease. And subsequently, we'll just move on to the question answer session and sort of summarize the entire talk. Now, when we talk about the history of sickle cell disease, so I think these are the key milestones or key people who have I personally feel, I mean, there might be a number of other people who have contributed, but these are the people who have made some significant contributions, which are like path-breaking contributions. So sickle cell disease is not a very old disease. The initial reports of sickle cell disease are just around 110, 115 years old, when Professor James Heinrich, a physician working in one of the hospitals in US, in 1910, he noticed these sort of abnormal shaped red cells in the peripheral smear of one of his patients who was a medical student. And he repeated it multiple times, thinking that it might be some sort of aberrant staining or something of that sorts. But again and again, he discovered the same findings. And this was the time when he said that this is probably a different pathology which we are looking at. So that was the initial discovery or initial thoughts about sickle cell disease. Subsequently, in 1948, this famous American chemical biologist by the name Linus Pauling, he actually gave a detailed description of molecular structure of sickle cell disease. Subsequently, V.M. Ingram, he gave the difference between the molecular structure, how sickle hemoglobin is different from the other forms of hemoglobin. So that work was contributed by V.M. Ingram. Then while all this was happening in around 1960, this lady pediatrician who was working in Brooklyn, New York, in armed forces, she observed that some of his patients who were suffering from sickle cell disease, and subsequently their kids were also diagnosed with sickle cell disease later in the life. In the initial years of life, soon after birth, they were protected from the typical sickle-related manifestations. And this, at that time, she attributed to a different form of hemoglobin in the blood, which is there in the initial years of life, which acts as a preventive hemoglobin for these sickle-related manifestations, which subsequently was proved in a larger study by Ora Platt and was published in NEJM in 90s, where they documented that if the fetal hemoglobin is more than 7.5%, the chances of having sickle-related manifestations are less as compared to if the fetal hemoglobin is less than 7.5. And then some beautiful seminal work done by Vijay Sankaran in early 2000, which was his PhD work, where he actually very meticulously showed that how this fetal hemoglobin switch happens. Before his work, people had no idea how this embryonic hemoglobin changes to fetal hemoglobin, to adult hemoglobin, and where all the problems can happen, where all the things can go wrong. So it was his seminal work, not only about the fetal hemoglobin switch, but also about the key drivers in this process of hemoglobin switch. And that is what people are trying to exploit at this point of time in gene manipulation strategies. A quick look at the burden of the disease. So we know that these two are the commonest diseases across the red cell disorders across the globe. Out of these two, also sickle cell disease is a higher burden. Around 300 to 400,000 patients are born annually across the globe with sickle cell disease. And these are just rough estimates because, as you can understand, and as Sir was highlighting, majority of this burden lies in resource poor or resource constraint setting, where unfortunately there is no registry-based documentation of sickle cell disease burden. But if we talk about India, approximately 10 to 13% of the global population of sickle cell disease lives in India, and the annual incidence is also approximately 10 to 30%. So that makes around 30 to 40,000 new sickle births every year happening in our country. So just emphasizes that we focus a lot about thalassemia, which is good actually, and all that discussion around thalassemia, advocacy around thalassemia has led to such a significant advancement in the care of of our thalassemia patients. But unfortunately, this disease, sickle cell disease, almost 4 times the burden of the disease, the significant morbidity associated with disease, but still this disease was neglected. It has gained some momentum since PMO's 2047 sickle elimination program was announced, but still a lot needs to be done. And the onus comes on us as pediatricians and more of pediatric hemato-oncologists to do strong advocacy around sickle cell disease. Now, the global burden of the disease, we know this is a very, known fact that the burden of the sickle cell disease more in the areas where there's endemicity for malaria, which is very clearly documented in this particular pictorial. So you can see the greener, the greener the area, the burden of the sickle cell disease is sort of more in that particular area. So these are the areas, dark green are more endemic for malaria, and you can see that the burden of the sickle cell disease is also more in these areas. Why we need to talk about sickle cell disease? If we look at these figures, 2010 vis-a-vis 2050, we can see that the burden of disease is nowhere going to plateau. It is just increasing, and it will continue to increase till 2050, and that is why we need to talk about sickle cell disease, both about preventive strategies, supportive care, and also the curative measures. Quick look at the pathophysiology. So we all know that it's a single base pair mutation which actually leads to formation of a defective mRNA. That defective RNA translates into formation of defective protein. This defective protein, which is a sickle protein, is vulnerable to sort of oxidative stress, and in such stressful situation, it changes its shape from biconcave shape to a sickle shape, and this sickle shape is actually vulnerable to both the complications, more of vaso-occlusive manifestations and also hemolytic manifestations. So whenever we see, it's a combination of both vaso-occlusive manifestations as well as hemolytic. However, we have very clearly, and all of us who are deeply involved in sickle cell care, we have seen that the spectrum is quite variable. We see that patients who have sickle hemoglobin of around 80 to 90%, but fortunately, they do not have any sickle vaso-occlusive crisis, but they just behave as sort of hemolytic anemia patients with regular transfusions, whereas we have seen patients, on the other hand, who have vaso-occlusive manifestations of sort of ischemic stroke in the initial 5 to 7 years of life. So it's a very variable spectrum, and actually, unfortunately, there's no predictor that this particular patient will have more of hemolytic manifestations. This particular patient will have more of vaso-occlusive manifestations, and that's where our actually clinical judgment is compromised. Now, when we talk about the treatment options, broad treatment options is care. As soon as the patient is diagnosed, patient needs to be started on optimal care, which includes hydroxyurea. We'll talk a little bit more about hydroxyurea because that's the only drug which has stood the test of the time. Vaccination, some key vaccine, apart from the routine vaccination, the vaccination against capsulated organisms is extremely important. Pain management, there's a very specific WHO pain management letter which needs to be followed. What happens? The problem which I have seen is that our management of sort of pain in the initial precipitation of crisis is not as robust, and that is actually where the problem lies, and this pain crisis exacerbates. However, if we hit hard right at the beginning, then the episode of the pain crisis will be much shorter. So this is something which we need to be mindful of. Red cell transfusion for patients, as I highlighted, who are in need of regular transfusions, and along with that comes the need of chelation. When we talk about cure, we all know there's a lot of discussion about gene therapy. I say it as gene manipulation because there are different strategies, which we'll discuss later in the panel discussion today. But awaiting a wider application of gene therapy, the biggest limiting factor is the affordability and accessibility. But we are trying hard to make it both affordable and accessible. But awaiting that, transplant is the only curative option. A quick look at the landscape of how the treatment landscape has evolved over a period of time. So it's interesting to know that hydroxyurea actually came after transplant for sickle cell disease. So the first known report of transplant for sickle cell disease dates back to 1996, when a patient suffering from acute myeloid leukemia also had a background of sickle cell disease, underwent transplant for acute myeloid leukemia, and got cured for both these conditions. And after that, people started exploring that option more. Hydroxyurea was actually introduced, repurposed for sickle cell disease in 1998. It is a beautiful drug with almost 6 to 7 mechanism of actions, and should be initiated on any patient who's symptomatic right early in early years of life. L-glutamine, again, a good drug, but not, I would say, in my personal experience, not as effective as hydroxyurea. But yes, it's a good drug to add upon. Crisan, Voxeltor, I will not talk much about it because we know that these drugs came with a lot of interest and enthusiasm, but unfortunately, because of safety concerns, these drugs were taken away from the market. And then gene therapy, which we all know. So 2 drugs are available. One from CRISPR and Vertex, another one from Bluebird Bio. Both of them, there were some concerns about the Bluebird Bio, but those concerns were nowhere related to the lentiviral vector. It was all because of the biology of the disease. So both of these drugs are beautiful, and they work very nicely and very effective. So it's up to us how we can implement these strategies in an affordable and accessible manner for our patients in need. Now, it's not only about the pathophysiology of the disease which decides the subsequent outcome of sickle cell disease. It's also a lot depends on demographic, and I think it's quite obvious. So we know that patients who are not very symptomatic in early years of life, but are from poor resource settings, they become early symptomatic quite early in life. And the implication of this particular finding, I'll emphasize on in my subsequent slides, that how this impacts in resource constraint settings. So basically, it's not about the pathophysiology which decides the severity. It's also about the demographics of where the patient belongs to, which decides the severity of the disease, and finally the outcome of any particular intervention which we make. Now, a quick introduction about transplants. Awaiting gene therapy, this is the standard of care. Conventional strategies have been used from 1996 onwards. So the initial thought was just myeloablative conditioning with calcineurin inhibitor-based GVHD prophylaxis. But unfortunately, because of the end organ damage in a number of patients, these myeloablative strategies come with a lot of morbidity and also mortality. So the focus has shifted from myeloablative conditioning to reduced intensity or reduced toxicity conditioning. And because of CNI-related complications, more risk of press and other complications, the focus has shifted from CNIs to mTOR-based GVHD prophylaxis. And I'll show you what we have tried to do making these modifications. So as I highlighted, the initial report was in 1996 when this patient of acute myeloid leukemia with a background of sickle cell disease underwent transplant and got cured for both the diseases. Now, transplant from research setting, a quick look at this. So this was a meta-analysis of around 1,400 patients, out of which 900 were sort of chiseled out and analyzed, out of which 55% underwent actually matched sibling donor, 137 underwent a haploidentical transplant, rest underwent a mismatched unrelated donor transplant. And as we can see that whether it was event-free survival or graft failure-free survival or the overall survival, the worst was in alternate donor setting. And when we talk about alternate donor setting also, matched unrelated donor and haploidentical transplants were sort of not doing nicely. Whereas for sibling donor transplant, the outcomes were fairly good. But how many patients do have a matched sibling donor? Just around 20 to 25% of the patients with sickle cell disease have a suitable HLA matched donor. So 80% of the patients are actually candidates for alternate donor transplant, where the success rate was not optimal. So this was the initial CIBMTR analysis. A quick look at the European colleagues. So they also looked at the data of alternate donor transplants, and as we can see, the overall survival, event-free survival and the overall survival were not great. It was somewhere around 65 to 70%, which was not as expected. Now, what about matched unrelated donor transplant? So this was was the work done by Shalini Shenoy, where she looked at the outcomes of match-related donor transplants for sickle cell disease. But this study was unfortunately discontinued prematurely because of poorer outcomes of match-related donor transplants as compared to HLA identical sibling donor transplants or even haploidentical transplants. But this should not be taken as a sort of core message, because there are new strategies, and there is a beautiful paper by Shalini Shenoy where they have used alemtuzumab-based conditioning in the past 4 to 5 years for match-related donor transplants in sickle cell disease with excellent outcomes. But these are just 1 or 2 studies. More data needs to make it sort of a frontline transplant options for sickle cell disease. Now, moving on to haploidentical. So if sibling donor is not available, MUD is not doesn't have very good outcomes in larger settings. So what options we are left with is just haploidentical donor transplant. Now, we all know about this seminal work done by Bolinos Mede, and they published their work in 2012, where they looked at 17 patients, 14 were haploidentical, 3 were actually identical donor transplants, but very symptomatic young adults or teenagers. The learning points were that overall survival was 100%, but the downside was that the failure-free survival was just around 53%. So almost 47% patients lost the graft. But people tried to build upon this particular strategy with optimizing the pre-transplant preparation strategies. And this was the work which was done at St. Mary's, where they focused on the pre-transplant preparatory strategies and also intensified the conditioning from typical reduced intensity conditioning to sort of reduce toxicity by addition of thiatepa. And this delivered very good results with graft failure coming down to less than 10%. Now, moving with this experience from the resource-rich settings, whether it's Europe or US, let's move on to the resource-constrained setting with example from what we have done. So this, as soon as I came back, this was the first patient. It was actually identical donor transplant, a very symptomatic child, had an acute chest syndrome at the time of transplant, was on NIV during the entire period, pretty sick, but fortunately sailed well and sailed through the transplant, and almost 12 years post-bone marrow transplant, doing excellent. This was another child, quite symptomatic, did not, only child of the family, underwent a haploidentical transplant. Again, 12 years post-bone marrow transplant, doing extremely well. So after these, fortunately, these were the 2 patients who were successful. But after this, using the strategies which we learned, which I learned at St. Mary's, the outcomes of the initial cohort of patients were not as good as we used to see at St. Mary's. And that's the time when I look back and try to analyze where the problems could be. And these were the things which I figured out are different in our cohort of patient as compared to the patients whom we were treating at St. Mary's. So different patient profile of sickle cell disease patients, improper access to optimum supportive care, hydroxyurea transfusion, which leads to higher and early end organ damage, making patient vulnerable to chemotherapy-related toxicities and both mortality and morbidity. Improper transfusion leads to increased risk of graft failure, hyperactive erythroid component because of the poor transfusions, increased risk of graft failure. And as I highlighted, with conventional myeloablative strategies, with end organ damage, there was a lot of morbidity, also accounted for mortality. So there was a feeling that something needs to be changed. Now, again, what people were trying to do is they were trying to take the same model of thalassemia and try to replicate it for sickle cell disease, which actually doesn't work. So what are the basic differences? In thalassemia, patients are on regular transfusion most of the times, okay? And their retic count is sort of fairly, marrow is fairly suppressed. Whereas if you look at the sickle patients, if they are not the sort of hemolytic manifestations, if they are just vaso-occlusive manifestations, they are not on regular transfusions, the retic count is sky high, 8, 9, 10, 12, 18. So that is the retic count, which just shows that how much hyperactive the marrow is. Non-liquid depleted transfusions, which is a very common practice in India also, and also in majority of the resource limited settings, which leads to both alloreactive in thalassemia, alloreactive T and B NK cells, which increase the risk of graft failure, GVHD, and primary graft failure. But how is it different in sickle cell disease? In sickle cell disease, although the transfusions are not that much, but just with one improper transfusion, patients can have alloimmunization. Why? Because the endothelium is quite inflamed. So even with one wrong transfusions, they have quite a significant risk of alloimmunization. Comorbidities in thalassemia, it's mainly the liver or maybe heart, which is a problem because of the iron damage. But when we talk about sickle cell disease, practically every organ in the body can be affected. So we need to be mindful of each and every lung. Is that affected? Lungs, liver is in a good shape, lungs are in a good shape or not, brain, kidney, heart. So all these things need to be taken into consideration. And whereas in thalassemia grade 2 to 3 early mixed grade 2 to 3 early mixed chimerism often leads to secondary heart failure, which is not the case in sickle cell disease. So mixed chimerism, I would say, is acceptable but not preferable because of obvious reasons. Now, so there was a felt need to modify the strategies, and what we tried to do were, we tried to incorporate pre-transplant immune suppression, which also helps in changing the conditioning intensity from myeloablative to reduced toxicity, or in some cases reduced intensity. Need to reduce graft failure. So what we did apart from PTI is we changed our strategy from marrow to peripheral blood. And in peripheral blood also, our routine sort of mobilization is GCSF and Plerixafor based, which we have personally observed that it leads to sort of less CD3 population in the graft. Then we have completely shifted from CNI to mTOR inhibitors because CNIs are more prone to cause CNS complications in both sickle cell disease patients and thalassemia patients. And to reduce the risk of GVHD while using PBSC, we have completely shifted to post-transplant cyclophosphamide. So these were the subsequent modifications which we made, and the overall objective was to improve the overall survival and event-free survival. So this was the protocol. I think all of us are aware of this, so I'll not talk much about it. So it starts roughly around 8 weeks prior to the actual transplant with 2 cycles of PTIS, augmented John Hopkins protocol, followed by post-transplant cyclophosphamide, MMF, and sirolimus as GVHD prophylaxis. We published our initial data. So again, a number of people are already aware of it. So the point which I want to highlight is, so in these very symptomatic patients, which was very different from the European or American colleagues, we were able to document overall survival and event-free survival of around 88%, which was 88%, which was very, very encouraging. What next? So initially for our match sibling, so this was the haploidentical cohort. But for match sibling, we were still using that completely myeloablative strategy. So either it was Bucy based or in some patients, TTF based with no PTIS. But what we observed was that the morbidity and mortality, morbidity mainly, not mortality, but morbidity was more, and mixed chimerism rates were also high. So we thought, let us try and replicate the same which we are trying for haploidentical for match sibling donors setting. So we extended this particular study. This was the initial thing. This has now changed, but the data was very, very encouraging with overall survival and event-free GVHD-free survival was very encouraging, both for thalassemia as well as sickle cell disease. So these are some of the graphs highlighting the overall survival and GVHD survival. And what we also observed, our initial thought was when we will incorporate this PTIS and other things, this will lead to poor immune reconstitution, increased risk of sort of viral reactivation. But what we observed was not at all different from the previous cohort. The immune reconstitution was fairly good at day 100, and the viral reactivations are also very much acceptable. So now we have a data of this is a old, apologies, this is the old data, but now as we talk, we have crossed 215 transplants for sickle cell disease. But more or less the graphs looks like this. The overall, I'll just quickly go to this particular paper which we recently published in Hematologica, which shows the outcome of 85 consecutive patients which actually identical donor transplants. Either from sibling donor, majority were sibling donors. I think one odd patient was an unrelated donor transplant. And as we can very clearly see that the outcome of these patients are very, very encouraging. So GVHD-free survival is around 93% and the overall survival is 96%. So again, I would say this figure as compared to our European or American colleagues, where they say that 98 to 100% is very different, because these patients whom we see are, I mean, they've held a lot of complications. Now, what were our learning lessons in this? That age is a very, very important factor. So what we observed was that if we take the patient up for transplant in less than 10 years of age, the outcomes are approximately 100%. Whereas as the age increases beyond 10 years, which in Western world, they take it as 13 years, but in our cohort, 13 years, because our patients unfortunately do not get that kind of a care. So the end organ damage, which is expected in the Western cohort at 13 years of age, that happens in our patient at around 10 years of age. So that's why this age difference is there in their data and our data. Role of PTIs, I think all of us know. Just for the youngsters to know the importance of PTIs in transfusion-dependent anemias and such setting, it addresses the hyperactive thyroid component, addresses the sensitized T cells and NK cells, helps in gradual lymphoid and myeloablation, gives us some time to prepare the patients in a better way. And there are multiple strategies which have been used. We use Fludex, Cyclo, hydroxyurea azathioprine, hypertransfusion. Some people have used ruxolitinib also for this pre-transplant preparation. But this is extremely important. So summary of our learning: HLA identical donor is the preferred donor. Success of haploidentical donor transplant is increasing day by day and is approaching close to HLA identical donor transplant, but still a lot needs to be done. What I would like to highlight is that the earlier the age, if less than 10 years, then believe me, there's no difference in the outcome of a HLA identical donor transplant with haploidentical donor transplant. We have addressed the challenge of graft failure. So in past, I would say 4 to 5 years, we have hardly seen a graft failure, maybe 1 or 2 odd patients. GVHD rates have come down. So this is again, even for haploidentical transplants, I think we just had a GVHD sort of grade 3, grade 4 GVHD in one patient in past 1.5 to 2 years, which unfortunately progressed. But otherwise, it has been addressed significantly. Age, as I have been highlighting again and again, is a very important factor, especially in our settings. Viral infections still remain a challenge, but with letermovir, I think a lot has been addressed. And with the wider availability of virus-specific T cells, as our cell therapy domain is growing in India, we'll be able to address these challenges. So problem areas, still patients with comorbidities, I think what we felt was that we need to work more for these patients and patients which are more than sort of 10 or 13 years of age. So what we realized is from all this learning is that one size doesn't fit all, and we need to optimize the strategy based on the needs of the patients. So these are some of the modifications which we have made on the backbone of the Apollo protocol, which we made. So these are the further optimizations in patients more than 10 years of age, where we have tried to reduce the intensity of thiatepa, built upon on TBI, some further modifications for patients with comorbidities. Again, this is quite variable for cardiac patients, for liver patients, for patients with renal comorbidities. So this is very different, but yes, this needs a more of an individualized approach. And all this work, I mean, has been done in with the help of a fantastic team of the clinical colleagues whom I work with, the nurses, the data managers, phenomenal support from all the hospitals wherever I have worked. And also, as we are moving ahead, we are trying to do our best to deliver better curative approaches in the form of gene manipulation strategies, working closely with some of the premier institutes in the country, such as DBT, IGIP, Jamia, and IIT Kanpur. So with this, I would like to thank you all for a very patient listening, and I'll be happy to take the questions now or in the panel discussion. Thank you very much.
Thank you, Gaurav, for a wonderful session, a crisp talk. We always learn from what you have to tell us. It's wonderful. And the scenario is very positive that outcomes are so good for sickle cell disease after bone marrow transplant, especially when it's a fully matched donor available. And even those who are lacking full match donor, the advent of haploidentical transplant is a changing paradigm. So we are open to questions. If anyone has any questions, they can type in the chat box and we'll take that question. So Professor Raj Warrior from US has written, why even wait till 10 or 13 years? Should you do it earlier if the donor is available and the course seems severe? Gaurav.
Sir, yes, sir. I think that's a very valid point. And just for the audience, I would like to tell you that under the guidance of Dr. Warrior, Dr. Yadav sir, and some other seniors, we are trying to prepare a set of crisp guidelines for transplant and sickle cell disease. That what are the indications, and what sir has the point which sir has raised is also very nicely addressed in those guidelines. So I think I'll not hesitate to take that patient up for transplant. Rather, even if the patient is mildly symptomatic but has a sibling donor less than 10 years of age, looking at our experience of almost 100% survival, I would definitely counsel that family for transplant, and then rest depends on their choice whether they want to go ahead or wait.
Wonderful. So until we have another question, I have one question. So Gaurav, as you have
Yes,
highlighted,
sir.
the results are excellent with the current regimens, and match sibling donor is nearly 100%. So it's so reassuring to offer this to patients who are suffering a lot from sickle cell disease and are symptomatic. So I have a question regarding long-term outcome. Like, okay, we have done the transplant for sickle and patients are surviving, no one is dying, or nearly everyone is surviving. So, do we have some challenges in the terms of long-term side effects and the other things? And what could be the strategies to sort of reduce the long-term morbidity or side effects of the regimens we are using in the present era? Thank you. And a
I think
comment about
again
therapy.
that's a very valid point. So I think a lot of focus now is on the endpoints. So I mean, for us under your guidance, the next thing to do will be to decide the endpoints of transplant. That how do we is just a sickle cell free life is our endpoint, or it's a different endpoint which we have to decide. Now, I completely agree with you that we have seen a lot of our patients struggling post transplant with different problems. I mean, joint related issues, or sort of stroke related issues, recovering from the previous stroke, previous hemiparesis. Chronic pain is such a debilitating thing. You feel that you have done your best, but still this patient, 2 years, 3 years down the line, still continues to be chronic pain, which is because of the nerve damage which has already happened, and we know that for these peripheral nerves to grow back is a very difficult task. So those are the things which we need to address. I think the key takeaway here is that transplant early changes the scenario quite significantly, because that will be the time when the patients will not have maybe no comorbidities or lesser comorbidities, and if they are not there, they are the patients who will do excellent post transplant. However, if you take a patient up for transplant with, say, lung disease or with liver disease, and even if you sail through transplant, those are the patients which will cause problems and have challenges subsequently also. So I think again the bottom line here is age. uh, as I highlighted in my presentation, the donor type comes secondary based on whatever our experience is. It's the age which is the key factor.
So earlier the better.
Earlier the better, undoubtedly, sir.
And Dr. Raj Warrior has another question. He says, Gaurav, is there any role at all these days for cord blood transplant for sickle? We had done few very long ago.
Yeah, so there's no role. I mean, I'll talk more about the Indian scenario, sir. Indian scenario per se, the cord blood transplant is just fading away. It has lost the entire sheen because of a number of challenges, because of a little bit delayed sort of engraftment, and that delayed engraftment of around 7 to 10 days comes with a lot of morbidity and mortality. And along that, on the parallel lines, the success rate of other transplant options, especially haploidentical transplant, has come up so beautifully that the cord blood transplant has gone down. And I haven't done any cord blood transplant. I have used cord blood as a top up in two of my patients, but I haven't used cord blood as the only source. And I'm sure based on the data which we have collected, not many cord blood transplants, rather hardly one or two might have been done.
Thank you. So there is another question by Pony. She is asking role of preemptive or prophylactic red blood cell exchange during pre-transplant immunosuppression or pre-transplant for sickle cell disease. Just a comment
Again,
about.
that's a very beautiful question, Pony, and very relevant in our setting. So, as my conventional teaching training in UK was that you have to strictly maintain your sickle hemoglobin to less than 30%. Otherwise, you will have this complication, that complication, and that was a regular thing to do. Uh, but
So
when we
it's
came here, you can understand that. doing a red cell exchange on a regular basis is not easy. It comes with a lot of challenges, the financial implications. So we try to manage them conservatively with sort of hyperhydration and not the sort of exchange transfusions, but regular transfusions to keep a hemoglobin more than around 10 to 11. And what we have observed now is that it does not make any difference in the outcomes. Uh, the challenges which we have faced is during the autologous backup. So for our haploidentical transplants, we still take autologous backup for all our patients, and in those settings we face problems. So what we have done is now that if the sickle hemoglobin is beyond 70%, we do a prophylactic red cell exchange to bring it down. However, if it is less than 70%, we try and maintain with the hyperhydration and other things. And in case the patient develops a crisis, then we do a red cell exchange.
So probably before starting the transplant, we should bring down HbS level to a decent level so that we don't have crisis in the middle of the transplant. So it can be handy. Well, the next question is by Swati Bhayana. She has asked experience with incidents of viral reactivations like BK and EBV virus post sickle cell transplant, matched sibling versus haplo. Is it more with haplo and your experience?
So EBV, Swati, is EBV we haven't seen, to be honest. We used to do EBV as a routine monitoring, but after around 70, 80 transplants, we realized that somehow the EBV incidence is lesser in our setting as compared to what we used to see in Europe. And it is all because of the previous exposure and the antibodies which are there. But BK has been a challenge for us, more so because the entire platform GVHD prophylaxis has now moved to PTCY. So BK is a challenge, but I would not say we have seen any patient with BK where we haven't been able to manage it. Has sort of led to some undesired results. But yes, BK is a challenge. I'm sorry, I don't remember the exact number of BK incidence of BK in our cohort, but it will be there in the Hematologica publication. But yes, BK is a challenge, but very much manageable.
There is another quick question. Sukirti has asked, what should be the upper limit of age consideration in matched sibling donor setting for sickle cell disease if no end organ damage is in the pre-transplant workup? So how long we should delay if the patient doesn't have many symptoms? How long should we wait?
So
I think that's
it's
what
in
she wants.
continuation to the question which Sir has asked.
Yeah.
So I would not wait. If we have a sibling donor, I mean, I would consider the patient up for transplant even with milder symptoms. So that's what the latest body of evidence says, and that's what is coming in the guidelines. You can feel that in the ASH guidelines which were published in 2025. The experience or experience sharing which we had while drafting the Indian HSCT guidelines also was the same, that if we have a sibling donor, these patients should be treated just like thalassemia patients and should be considered for transplant, even with
So I
mild
think
symptoms.
where time is running out. Professor Raj,
I agree totally, Agarav.
comment. Yeah. Dr. Raj, yes, sir, please go
Sir.
ahead. Unmute yourself. You are muted, sir. Yeah.
As I agree totally, because if you've seen old sickle patients suffering, I'm totally for that. If I don't do it as soon as possible before they get organ damage. Good thought.
Thank you.
Thank you.
So, Gaurav, one last question. Is GVHD free survival similar in sickle cell disease as in thalassemia transplants, especially in matched sibling donor setting? I know it's a difficult question.
Yeah, I think
Is
that
it
head-to-head comparison has to be done.
Yeah.
I would say for us, the data, the experience is more with sickle cell disease. But more or less for sibling donors, I'm saying unrelated donor is a different scenario for thalassemia as well as for sickle cell disease. But for sibling donors, it is more or less the same. GVHD survival, especially with the PTCY based strategies, is more or less the same.
Wonderful. So we'll finish here. Thank you, Gaurav. And it was a wonderful session. We truly enjoyed that. Now we'll move to the next.
There's one question by Alaka. Yes, just a single word. Yes, we use both. For both, we use the PTCY.
Okay, so we finish here now and move to the next part. Gaurav, thank you. So the next is the panel discussion, and Dr. Ajita will introduce the moderator and the panelists. Over to Ajita. Thank you.
Thank you, sir. That was a wonderful session by Dr. Gaurav, sharing his experience with about 215 transplants on sickle cell patients. So the next session will be by Dr. Sunil Jodhale, who is an additional professor, Pediatric Hematology and Oncology Department in AIIMS, Raipur. So I hand over to sir to introduce his panelists and take over. Thank you. I'll be sharing the screen from my side. So over to you, sir.
Okay, am I audible now?
Yes, sir.
Yeah. Thank you, Dr. Gaurav, for a wonderful, deliberation on, transplant and sickle cell disease. So, we have a wonderful panelist and one of you as a main lead. So we have Dr. Gaurav Karia, who has just now given a wonderful talk. Who's a consultant and director at Apollo Hospital, Delhi, and one of the leading transplant physician in sickle cell disease, particularly. Then we have Dr. Ankit Parmar, who is consultant pediatric hematologist at HGHOC Hospital, Surat, and he will be hosting. Yeah. And then we have Dr. Atish Bakane, who is a consultant pediatric hematology and BMT at KIMS Kinfay Hospital, Nagpur. And we have one medical scientist, Dr. Saili Tiwari, who is a scientist at ICMR Center of Hemoglobinopathy, Chandrapur. So we'll be having, panel discussion on transplant and gene therapy. We'll be going more of, hook to transplant as the right questions by asked by Dr. Warrior and, other panelists also, attending. So this is just a overview of sickle cell disease. You can see, that it's a classic triad of sickle cell disease, which consists of hemolytic anemia, vaso-occlusive crisis, and recurrent infection. So this triad ultimately lead to vasculopathy and multi-organ damage and early mortality. Next slide, please. And we know there are a lot of genetic and non-genetic modifier of phenotype severity of sickle cell disease. And the most commonly we see at phenotypes, which is we are Arab Indian, which considered to be less, but there is not true overall as overall. And some of the children actually have a severe presentations. And then we have non-genetic modifier like in our country, there are like a lot of, temperature, air quality, and other issues, which also, affect the severity of sickle cell disease. Next slide, please. Next slide. Okay, so I just skip most of this and just, okay. So we target the pathophysiology of sickle back. Okay, pathobiology of sickle cell disease, and these are the common targets, and the most common doctor, and the earliest one was BMT, and then come the hydroxyurea. So we target with hydroxyurea with HB, increasing HB production, like hemoglobin production. Then there are like HBS polymerization has been targeted, but the drug has been not been very successful, oxidator particularly. Then vaso-occlusive, the adhesions are not been very successful, and there are a lot of other mechanisms which we are going to target in coming time. Next slide, please. So these are the complications of sickle cell disease. While we just see at the severity at the baseline, how much frequent VOC and other complication has. We do not look many of time what complication they are going on unless we regularly monitor. So most commonly we see is avian in our scenario, pulmonary hypertension, then sickle hepatopathy, strokes, retinopathy, and pulmonary hypertension as the most common complications. Next slide, please. Okay, so these are the treatment options we just talked. So apart from this hydroxyurea, we have limited drugs now. L-glutamine, this Griza and Voxelotor has been out of context now because a lot of complications. But we have hope with gene therapy and transplant. Next slide, please. So with this background, I would like to start with Dr. Saili, who is working at the best, at the Chandpur, the hub of sickle cell disease. So Dr. Saili, what do you consider as optimal medical treatment and good clinical response in sickle cell disease before you consider curative treatment like transplant or gene therapy?
Yes, thank
Saili, please.
Yes, I hope I'm audible. Thank you for that question,
Yeah.
sir. And I'll start with the basics. Now you're talking about gene therapy and all, but when the region I'm working in where there is high prevalence and still we consider it as a resource constraint, we focus mostly on care which we provide based on medication. So if I'm a practitioner in periphery, so the optimal treatment or the management plan would be based on the age of the patient, where if the patient is less than 2 years of age, we don't start hydroxyurea as per current guidelines. So between 0 to 2 years of age patient, mostly we expect them to be on penicillin prophylaxis and folic acid and appropriate vaccinations. And now pneumococcal vaccine is already covered in the national immunization program. So at least that part is taken care of. This is the first. So now if the patient who comes to me is between 0 to 5 years of age, then we initiate them on hydroxyurea, continue with the penicillin prophylaxis. And more than 5 years of age, there is no role of prophylaxis, antibiotic prophylaxis, and hydroxyurea is continued. Initially, what we have observed in our OPD setup and like other patient interactions, the starting of hydroxyurea is fine. So the starting dose, which is 10 to 15 mg per kg, which is expected when we start the patient. We are expected to monitor them CBC is monitored every 2 weeks and other biochemical parameters maybe once a month. And if the dose is optimum, then we escalate if the response is optimal, it is escalated till the maximum tolerated dose is achieved. That is the ideal expectation, or that is the ideal course of action which is expected. But what usually happens, or what I have seen, is patient is initiated on hydroxyurea, but the dose is never increased up to the maximum tolerated level or the expected level, and the patient still end up with a crisis or whatever XYZ complaints they will have. So ideal response or optimum management or optimum care, which I would consider is patient is at the age appropriate, whatever management that is expected. So appropriate dose, which is the maximum tolerated dose, which we can consider based on his hematological parameters like reticulocyte count, platelet count, MPV, as well as what is the clinical response to the treatment, whether there is reduction in the pain crisis or vaso-occlusive crisis. What is the incidence of acute chest syndrome in those patients after starting initiating them on hydroxyurea? And is there any evidence of end organ? These are the three basic things which we will consider. And if that is optimum, that is as per the protocol, as per the guidelines, and patient is clinically responding well, then I would
Just go to next slide, please.
then I will be considering him or her as a optimum response.
So Dr. Saili has already spoken this. So optimal treatment, basically you have to go hydroxyurea optimal dose. That's very important. Many times we just give a small dose, 10 to 15. We expect that everything the patient should get all right. And without monitoring end organ, it will not be difficult. It will not be easy to say that how the response is. And we have to always talk about their complaints. So this is basically a good response we define. So complete more than 70% of complete registration of vaso-occlusive crisis, ACS, and the hematological stabilization. We consider at least hemoglobin more than 7 as a good hematological stabilization. Okay, and there is no evidence of organ dysfunction. So we coming to Dr. Ankit. Yes, next slide, please. So Dr. Ankit, as Dr. Ajita has said, once you optimize the treatment and you see their compliance, so which patient of sickle cell disease you consider for a transplant, and when you actually refer them to Dr. Atish, Dr. Gaurav, or a transplant physician in general?
Yeah. Thank you, Dr. Sunil and PhD chapter for organizing the webinar on sickle cell. So who needs the transplant and who needs a curative therapy. We need to shift our mindset from who needs a transplant to who needs a curative therapy first. Okay, information wise, every patient should get the information that bone marrow transplant is a curative option for sickle cell disease, and patient wise, whom patient should be referred to a transplant facility in which patient should be referred as soon as possible before the end organ damage is evident. Because in 2 to 10 years of age, when the transplant is happening, the outcome is excellent. It is approaching almost 90%. So some set of patient where if the transcranial Doppler velocity has been monitored, if it has been more than 200, or there are some minor or silent cerebral infarct, you can send that patient. A patient who is not responding to our proper medical management, that is hydroxyurea or and/or transfusion therapy, and patient is having a lifestyle life quality difficulty because of frequent vaso-occlusive crisis or pain crisis or acute change syndrome, that patient has to be referred as soon as possible. Uh, because we know that some patient even don't come to the facility and they died. In Surat, we have seen in past that even almost 20% of patient died before the 2 years of age, and even 30% of patient doesn't reach to adulthood. So these are the tip of the iceberg because sickle is evident in very interior part of the our India. Some of the patient may not get registered also. So the picture is bigger.
So I just want to highlight here because the question was asked by Ariel sir and Dr. Yadav also. When to refer? I think that patient at least one time has to refer to transplant physician to counsel them and at least see the feasibility that okay whether they have match sibling donor. So that can be done early rather than once they develop organ dysfunction and severe disease. So this basically, okay, please go back. So this, as Dr. Ankit said, there are a lot of mortality recently, this Surat area, and this has been documented also. So we need to refer them early. And once the patients agree, so this let the patient decide, if they want to go for a transplant and if everything is available. So the shift is now the who need transplant to who need curative therapy. So this curative therapy is to be decided by the patient with the counseling by transplant physician as well as the treating physicians. So this was the study that I think this Dr. Ankit was talking. So now coming to a transplant physician, our Dr. Atish, who is working in Nagpur. So Dr. Atish, which patients actually you accept for a transplant with, you say, probably say, okay, well, has a good outcome, give them a good hope. And which workup you do pre-transplant apart from your standard transplant workup in patients to evaluate particularly organ dysfunction in sickle cell disease. Dr. Atish, please.
So thank you very much for that question, Dr. Sunil. And I think this has been addressed a bit by Dr. Gaurav sir and even Dr. Ankit. So ideal candidate, sickle cell disease less than 16 years, so preferably less than 10 years in India, as the Apollo data suggest, who has fully matched sibling donor available, and obviously preserved organ functions, because like after 10 years we know that these patients developed many hepatic injury or kidney injury and end organ damage in many other areas like lungs. So these are the best patients with very good outcome. So as the Apollo data, even our data here, the outcomes are phenomenal if you are doing matched sibling donor transplant. So it's a dream. A sickle cell disease with matched sibling donor less than 10 years, they don't have much problems, and we can give absolutely good outcome, like to the tune of 93 to 95%. And addressing your second question, so sickle cell disease, so every disease is different, and we know that this in sickle cell disease itself there are different patients, they behave differently. So and particularly when we are transplanting these children, we should be aware of their on a pre-organ status. That is most important. Like if you are talking about neurological status, that's important. You should have MRI or MRA angiography beforehand, that if you have some structural silent infarcts or moya vasculopathy, so we can be well prepared for subsequent challenges. Like we know these patients can have sometimes brain hemorrhage, so we and seizure prophylaxis also we can decide. Talking about pulmonary and cardiovascular, we know in these patients can develop pulmonary hypertension subsequently, so getting an echo done, which is standard in other this, but in particularly in sickle cell disease, it's important. Hepatic and renal, very important. Many, as you rightly said, in many our area particularly, we have seen a lot of hepatic injuries. Very less than 10 years, we have seen few patients with. So if you have that idea, like how is the liver performing, so either microalbuminuria, creatinine clearance, if you can calculate earlier, and other parameters, if they are some sickle cell disease patients are on transfusion, so like thalassemia, the type of workup we should do, get fibroscan and keep them well. Renal, many patients in less than 10 years I have not seen here like affected, but yes, we should have their good renal parameters, get GFR done. Many patients are on transfusion, so like immunization, if it is there, we should definitely be aware of. Other organs like ophthalmic checkup, whether they have retinopathy or not. AVN, many of our patients are AVN, so I think better to have that MRI done, and as a project in ICMR and all that's being done. Pulmonary function test, we know that sickle lung disease is common, stage 1, stage 2 being indications, so better to have pulmonary function test. Transcranial Doppler, yes, as a routine, I think we should be doing for the children from 2 years onwards, because many patients in like even less than 3 4 years. Yesterday's OPD also we could pick 2 to 3 patients in ICMR. They had hugely elevated transcranial Doppler velocities. So all this workup is important. I think most of the transplant patients we do this workup, but in sickle cell disease, how to go about the challenges that we may be facing later on. I think we should get all these things done. Thank you.
So I will come to ask again that question. If somebody has that organ dysfunction, how the outcome differ? So I think the question again we have to ask what happened to the many patients. This is very important. Uh, After they are no longer in follow-up of a pediatrician, because if they're not, keeping the patient lifelong follow-up is again a very difficult, and taking treatment such a long time. So if possible, we have a match. I think going for a transplant is also good options. Right. Next slide, please. So this is the workup has already been highlighted by Dr. Atish. Next slide, please. Okay, so I think this is the study we have come across commonly, how we treat sickle cell disease with the transplant. Next slide. And you can see the severity criteria for initial international medicine trial. So these are basically the patients who have been taken for a transplant initially with a stroke, ACS, recurrent VOC, more than VOC in a per year, impaired neurological function or abnormal brain MRI, stage 1 or 2 sickle lung disease, sickle nephropathy, bilateral proliferative retinopathy, because these were the criteria. They were the severity criteria for transplant. So next question, next slide, please. So I'm coming to Dr. Gaurav. So sir, what is your plan of transplant if you do not have matched sibling donor? We already talked a lot of sibling donor. If it is not available, and what are the pros and cons of doing unrelated matched donor versus Apollo transplant versus second line therapy? Sometimes this may not be very good outcome, like because of Apollo and all this. So what do you consider? Yes, please. Gaurav sir. Unmute, please.
Yeah.
Yes.
Now I muted it. So I think if we do not have to just simplify this complex question, if we do not have a sibling donor, patient is less than 10 years, 10 years of age, and a symptomatic patient, we will consider for transplant for sure, even if with a haploidentical donor transplant based on the outcomes which we have currently. Mud transplant, as I have shown you, whatever data we have on mud transplants globally, do not show that they have better outcomes than haploidentical transplant, which is in a way different than thalassemia cohort. But having said that, there is recent data which is coming up where outcome of unrelated donor transplant with the newer strategies of PTCY abatacept is equally good. So I think to comment authoritatively on that, we'll have to wait for some time. We'll have to have some in-depth data on unrelated donor transplant with these newer approaches. But as of now, if you do not have a sibling donor, the next choice is a haploidentical donor, less than 10 years, lesser symptoms. We will definitely go ahead. More than 10 years, patient is quite symptomatic. If you feel that it will be difficult to sustain for 2.5 years till the time gene therapy is available, then we will consider the patient for transplant with our modified approaches, which we have tried to optimize in past 5 to 6 years, because with modified approaches also the outcomes are fairly okay for these adult patients. But if the patient can wait and you do not, and especially in the alloimmunized settings where transplant can be really, really challenging, more challenging than at times than your borderline end organ damage. Those are the patients where we would like to wait for another 2.5 years to 3 years and sort of offer them gene therapy.
Nicely answered, sir. Next slide, please. So, next slide. So I think this is a very relevant question because Dr. Gaurav, how many of patients you see actually get a sibling donor? Because historically it say that only around 15 to 20% get a sibling donor. How many times you get a sibling donors?
No, this is the statistics is the same. Around 20% is the chance of finding a sibling donor. 80% do not have a sibling donor. Of late, we have started finding unrelated donors for a number of our patients, and probably that data will build up in some time. But yes, you're right, around 15 to 20%. And this is lesser than actually thalassemia. In thalassemia, it's around 25% to 30%, whereas in sickle cell disease, it is around 15 to 20%.
So we were talking about second line therapy also because apart from hydroxyurea, we not have much drugs. The Vaculator and Pizza has gone. So now the newer coming drugs like PK activator is coming up. So what is your take on PK activator? So do you feel any hope those who are waiting for a transplant and those who are not having a match, or there may be more complication with the transplant?
Yeah, I think as a bridge, yes, we can consider, but I would just like Voxetor and Crizan, which was a very disappointing sort of story for PK pyruvate kinase drugs also. Whatever data we have actually from the RISE trial, if we just try to dig a little bit more deeper into that particular trial, for which was for mitapivat, the average increase in the hemoglobin was just 1 gram. So little bit encouraging results, but I think these are still quite early days to comment on it, that whether it can replace as a second line therapy after hydroxyurea or not. I think we'll have to wait for some time because the data at this point of time is not as robust to comment on that. Whereas for transplant, actually the data is building up very solidly to say that that's the way to move ahead.
So I think you already commented on this, that this trial of unrelated donor marrow transplant for children with severe sickle cell during your talk. I'm not going in detail. So next slide, please. So this is the question joint can answer Dr. Atish and Dr. Gaurav. So what are the challenges of you face children with sickle cell disease particularly? Those who are doing early transplant, early age, late age, and early complication, late complications. And what are the effect of organ dysfunction? Somebody has like AVN, stroke, pulmonary hypertension, or nephropathy, or retinopathy. So how do you tackle them while you take these treatment for a transplant? Yeah, Dr. Atish, you can answer first. Dr. Gaurav can.
Yeah. So I think the challenges of doing, I think that has been already discussed. So sickle cell disease has few challenges which are a bit different or maybe additional to what other diseases can have. But if you talk about early challenges, they may be conditioning related. Initially maybe veno-occlusive disease, which is very less likely compared to thalassemia and other diseases. But one thing is more important in seizure potential. These diseases we have seen when earlier we used to use calcineurin based protocol like GVHD prophylaxis. The seizures were quite significant, but since last 5 or 6 years, and when we are using sirolimus based prophylaxis, I think hardly any patient developed seizure per se in the early phases. And late challenges that patients can develop GVHD. Obviously, chronic GVHD can be there. And particularly in sickle cell disease, I think secondary malignancies has been a challenge. I think in Apollo data, 1 or 2 patients developed secondary malignancies subsequently. Uh, Talking about organ dysfunction, I think this is the same question. So if we had earlier, if you know that patient had developed stroke, so these patients have lower threshold of some hemorrhage. However, in our data, we have not seen much of intracranial hemorrhage post transplant. Pulmonary hypertension. So if patient had earlier developed pulmonary hypertension, so it can have right heart failure. Avascular necrosis doesn't make much difference, particularly I think in the transplant. But yes, if you have to give steroids for long term in if somebody develops GVHD and all, so I think that can initially transiently worsen that AVN or ischemic pain. One more important thing is, and these poor patients, even if we transplant, for the first year, many patients developed some sort of vesicular crisis, some sort of pain. But like almost, if you see the literature, 20 to 30% patients can complain sometimes. In my court, I have seen complaining of pain abdomen, some, for next 1 year. I think that these are some specific challenges that I could see in sickle cell disease.
So, Dr. Gaurav, specifically, I would like to ask which organ dysfunction, if it is already present, existing, which are going to improve it and which are not going to improve. You have to tell the patient, okay, you are going to expect, okay, everything will improve. So, I think what is your opinion?
Neil, that's a very, very good question because I think I talked briefly about the endpoints. And endpoints become very important in such diseases, for which, regarding which we talk less about it. But I think we need to be more categorical in why we talk less about these endpoints, that what will be achieved, what not will be achieved, which gives a fair bit of understanding for that patient to decide कि भाई मुझे क्या फायदा होने वाला है ट्रांसप्लांट से और क्या नहीं होगा, because they entering into a transplant with this hope that grade 4 avian will recover. That's a false belief which should not be there, because they feel disappointed that okay, I got the transplant done, but still my morbidity still remains the same. Into it, it's a long list, Sunil. So I think let's just wait for another 10-15 days. We'll have beautiful set of guidelines, as I said, which explains each and every organ, that which organ has capability to sort of resolve till what extent. For example, like avian. So avian is stage 2 and below. You can tell the patient confidently, yes, that post transplant there's a fair bit of chance that this avian can resolve. However, if it is 3 and beyond, then the chances are less likely. So that gives you a comprehensive idea about which organ damage, to what extent pre-transplant will resolve post-transplant, or all will persist. It's a detailed discussion, but as I said, let's just wait for another 15-20 days. It's a beautiful set of guidelines prepared under the banner of SPECT, under the guidance of all the senior people, and that will answer all these questions.
Yeah, hope we are hoping for this, and we are waiting definitely for this. Particularly sickle, spleen dysfunction. What is your take? Like whether it's like does it improve or it's basically because already the spleen had damage. most of time it is like, and whether its function will improve or not, because that has a lifelong implication on the risk of infections. So hopefully that question also we will planning to get for guidelines. Okay, so this is basically the next slide, please. Okay, so Dr. Gaurav, again I'm coming to you. So changing from the transplant. So we are waiting, and actually I heard many times in many conferences that gene therapy is around the corner and around the corner. I want to know how much is around the corner, and what is current status, and what are the technical issue, cost, feasibility? Can you, because you are the leading person on this in gene therapy in sickle cell disease.
So can I? Is my slide visible? I
Yes,
just
yes.
is it visible?
Yeah, next slide, please. Yes.
No, is my slide visible? I have projected a slide. Is that visible?
No, sir, I have to stop sharing then once again.
Just briefly
You
do
want to
that.
share? Oh, okay.
Yeah, just one
Yes,
slide.
sir, Dr. Gaurav, your slides are visible, I think.
Yeah.
Yes, please.
So this is the answer to your question, that where do we stand as a country? So these are the basically four, or I would say there might be other groups also, but as far as my understanding goes, these are the various different groups working in gene therapy space for both thalassemia and sickle cell disease. So the initial two, Sarvana and Mohan, they're doing brilliant work at CMC. One is on base editing, and another one is lentiviral vector-based gene manipulation. A fair bit of work. If you want to know more about what they're trying to do, at the bottom are the publications which they have done in 2025, 2023, 2024. Then Debo at CSIR, IGIB, again, the very nice work being done on CRISPR-based strategy, which we are aware of, the BIRSA-01, CRISPR and FN-Cas-based genome editing. So that's another group which is working very actively for sickle cell disease, and we are also trying to do our bit at Cellugen. We have worked on both the strategies. So I think two strategies are there. One is LV based, another one is CRISPR based. We have been working on these strategies for past 7 years, and both of them have delivered beautiful results. But we are trying to move ahead with the LV-based approach, and the reason for the same is first of all, there is no difference in the CRISPR-based approach versus LV-based approach. Second thing is, whatever therapy, I personally believe, whatever therapy we develop or we come up with, until as the therapy is a cost-effective therapy and is not accessible to all the people, it just defeats the purpose of whatever innovation you are trying to do. And with LV, our own strong point was that our LV manufacturing is very, very robust. So all our platforms, for whether it is for ex vivo CAR T cell therapy, in vivo therapy, is LV based. We tested the transduction efficacy in the CD34 cells is excellent, and that's the reason why we want to move ahead with the LV based approaches, and we have kept actually CRISPR aside. Because the royalties associated with CRISPR are quite complex, and when we actually try to bring it to commercial setting, it might not prove cost effective. The whatever innovations people have tried to make, that revolves around Cas9, but the royalties mainly of CRISPR and not on Cas9 as far as my understanding goes. So that's where the complexity arises, and that's why we have taken this decision to move LV-based approaches, which is working beautifully. Fair bit of work has been done. I think all these four groups are working parallelly. So hopefully, in future, we will not have one therapy. We'll have 2 or 3 approaches, which include CRISPR-based genome editing, which includes base editing, which includes LV-based sort of gene disruption. So this is where we stand as a country.
Gaurav, what age do you recommend gene therapy?
Sorry?
What age do you recommend doing that as well?
Sir, recommending age and the initial age will be very different. So our regulators, I'm sure they'll not at all allow us to use it less than 12 years of age. So that will be the starting age. For phase 2, we might sort of try and convince them to bring it down to around 3 years or 5 years of age. But once we have success, once we've documented the success and the confidence is there, then I think, sir, I don't think 5 years down the line, I'll be offering transplant to any of my patients. I mean, allogenic transplant. I'll be taking them considering all for gene therapy, especially when the gene therapy can be delivered in a cost-effective manner. And the way the landscape is changing, sir, it's just a matter of time. 5 years down the line, we'll be having in vivo gene therapy, just the way we are having in vivo CAR T cell now. So it's a very fast evolving landscape. I personally feel that 5 years down the line, we'll not be offering allogenic transplant to any of our patients.
So
Thank
this
you.
will be really good to patient who does not have a match, as well as those even those who are a transplant and not suitable to take a transplant. I think so. We are very hopeful for many patients actually. Can you share? Let me share again and.
Yeah, your screen is visible, Sunil. Yeah.
Yeah. So you can show now. I will go to okay. So is it visible now?
Yes, it is.
Okay. So I think this is the gene therapy we all know, and this is the process. Dr. Tagore has already spoken out it. So and he has a very aptly summarized the barriers as well as infrastructure regulatory problems. And so this is the CSR already, sickle cell anemia mission already state that it will be largely available to the patients. So coming to Dr. Atish again. So Dr. Atish, if you have choice, like this is again, many of the parents will be actually asking you. So you have a matched sibling donor, unmatched, unrelated matched donor. So you have donors either way. So what do you prefer? If the cost is not constrained in like 5 years later, like you will go for a transplant or gene therapy.
So if they approve less than 12 years, I'll go with gene therapy, but even particularly in my sibling donor transplant. But if not, I think we have enough data to and follow-up data to suggest that MSD is much easier, and you can go ahead. You can. I will be very happily offering my sibling donor in less than 10 years. Mud there, it's not a brainer. Definitely, we have seen a lot of problems with mud in sickle cell disease. So gene therapy absolutely will win the race here.
So I think that definitely will be again problem. Like the patient will be like matched sibling donor versus gene therapy will be that time will be. Dr. Gaurav, you want to say on this like matched sibling donor versus gene therapy? It is like
I think
in a 5 year like if you have this question,
I
somebody
think
asked.
look, I agree with Atish. As a success rate of matched sibling donor transplant is excellent. So that definitely still remains. But look, 5 years down the line, when we have available option and if possibly we have a in vivo approach available for gene therapy where the patient doesn't need even conditioning chemotherapy, I think the things will be very different. I mean,
Yeah, definitely. But
this point
the
of time,
matched
you have
sibling donor.
seen that.
Yes, please.
Sorry, you have seen the landscape how significantly it changes. I mean, Johnson and Johnson started their bispecific CAR T cell program, and after a very encouraging phase 1, phase 2 data, they just junked it because they thought that ex vivo approaches are not going to work for CAR T cell, and they moved the entire platform to in vivo approaches. So same is going to happen for gene therapy as well. The in vivo approaches are coming up very fast. So once that is there, because then your ex vivo processing, your lymphodepletion, all those things are sort of sorry, your myeloablation, all those things are addressed to a great extent. So that's a little bit difficult question, MSD versus gene therapy. As of now, it is MSD is preferred in Europe because of obvious reasons, and I personally believe that cost is a major driver because the cost of gene therapy is like altogether 3.5 to $4 million, whereas the cost of transplant to the insurer is just say around $500,000.
Yeah, so maybe this may be the question when we have enough data on gene therapy, and it will be very less cost effective. So, Dr. Atish, I think this has already been answered. I think. Okay. So this is the curative treatment comparison, match haplo and autologous CRISPR. So the only thing is like there will be compared to the match sibling donors, it says that more than 90% elimination of UOCs. And in a match sibling, it says still 80 to 85 to 90%. So I think, but the cost definitely is very, very close. So coming to next, we are again Dr. Ankit. So how to manage a patient with sickle cell disease not responding to hydroxyurea, and and practically in our country, many times transplant is not possible. The most issue will be cost. Sometimes patient don't want to spend so much time in the hospital 6 months, or they have severe organ dysfunction. We cannot go for a transplant. So what are the options you give them for a management? Dr. Ankit, please.
That is the scenario of currently 95% of our patient who we are dealing with the hydroxyurea. But once the hydroxyurea doesn't work, then we have a very limited options. And as Dr. Gaurav Kharia has already said that all the options that available are not very promising. Results are there, like L-glutamine, zinc therapy, the pyruvate kinase activators, voxelotor, crisazolam came with all the gun blazing, but the results were very disappointing. So if we say in practical terms that only chronic transfusion therapy like thalassemia is the only practical treatment that we can offer to the patient who are not responding to hydroxyurea, or they are facing some kind of toxicity, where our target is not the maintaining hemoglobin but the HbS level less than 30%. So we can put them on chronic transfusion therapy and see manage them like a transfusion dependent anemias, and support them with minimizing the side effect with some lifestyle modification, maintaining hydration and etc. thing.
So I think unlike thalassemia, we have to go for exchange transfusion, whether automated or manual exchange transfusion, depending upon hemoglobin. If the hemoglobin is less than 8, we can go for regular transfusion therapy. If the hemoglobin is on the higher side, we have to go for exchange transfusion. Because if you give a transfusion in a child who has more than 8, there are higher chance of hyperviscosity, and we have seen few patients with IC bleed leading because of the more transplants. Okay, so these are the therapies has been listed. Lot of coming up, but many of them are still under study, and we have not gone. So interestingly, I have come across these some biological treatments. I don't know many of you have seen these are been listed in literature. Particularly, this is found in Himalaya. This Angelica arcangelicia. So basically, this, and you commonly see this bell fruit, the fruit you can see in anywhere in India. So this is also can be used. This citrus, this look like our small lemon, but it is yellow in color. This also has been utilized, and this badam, oil, which is grown in many of the homes. So this, and as well as the black angurs, this Vitis vinifera. So this has been listed, and this pharmacological action has been studied actually, and the inducer in the actual ingredient of this various biological source has been identified. But we need, definitely need more study. We don't know. I don't think we have any Indian studies on this ingredients. Okay, so Dr. Saili, I'm coming to you again. So what are the genetic markers and clinical phenotype of patient of sickle cell disease? Who need a transplant or genetic gene therapy early? So like currently we can say just transplant. So even though do not have many severe disease early, but some genetic markers or any specific clinical phenotype which make you to decide this patient should go for a transplant.
So rather than genetic markers, I would say they are genetic modifiers which will affect the clinical course of the disease. And first and foremost is alpha thalassemia co-inheritance. So in our patients, if there is co-inheritance, then the severity is expected to be reduced. But however, the prevalence of this alpha thalassemia co-inheritance in Indian population is hardly maybe 10% of single gene deletion and maybe around, if I'm not wrong, 3% for double gene deletion for alpha thalassemia. So this percentage is still less compared to the total number of sickle patients we see. If we come to the haplotypes, then anyway, our Arab Indian haplotype is associated with higher level of hemoglobin F. Despite of that, there are certain subphenotypes in which what do we say? The subphenotypes where there is we see the severe manifestation or severe presentation like sickle beta zero thalassemia or things like that. Apart from that, direct genetic markers, although they are not available, there are certain genes which have been studied which are associated with increased mortality or specific clinical complications or end organ damage, like BCLA11 and these kind of genes. But all in all, I think it is more like what is the clinical presentation which will lead us or direct us towards the decision for taking stem cell transplant.
So we have this commonly, homozygous sickle, then HBD Punjab, and HBS thal, beta zero thal, sickle cell. So this is basically the most common phenotype which are present with the severe sickle cell disease. And if you have a mass sibling donor, I think I will like to refer them early for transplant if the parents are agreeing and they have sibling donors. So these are basic the common and there are mild and moderate where you can wait also. Like we have something like moderate beta sickle beta plus thal. So these patients do well. So we may not transplant them even they have a matched sibling donor if they are doing well, right? So this is the basically genetic modifier. Apart from this clinical phenotype, we come across like TCD, we come across the recurrent VOCs, any episode of a single episode of splenic sequestration, and more than 2 episodes of acute chest syndrome, and increasing pulmonary dysfunction or pulmonary hypertension, stage 3 AVN, and blood transfusion dependency. Like the child has a persistent less than 7 hemoglobin with growth failure or a persistent 5 grams. So this commonly we see in our practice. Dr. Saili has highlighted some other like BCL also. So Dr. Atish and Dr. Gaurav, again, I'm coming both of you. So what are the post-transplant issues in sickle cell disease? So how do we monitor? I think this dysfunction you already improved. So any particularly, I would like to ask you to monitoring post-transplant these patients, because some of the patients actually come to me also post-transplant, and we also see them. So how specific monitoring you do particularly in these patients?
The monitoring is very, 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 very important, and that is where the shared care comes in picture. So first of all, what phase of transplant are the patients in? That will decide what investigation needs to be done, what needs to be monitored. So like immediately as a dictum across the globe, we see till day 100 and till day 100 the patients are at the primary center, and then they usually go back for shared care. But the treatment intensity should not get compromised. That is that from that particular day 100 till around 8 or 9 months, they need to be followed up with all the stringent post-transplant investigations, the immune suppression, monitoring, and sort of titration of the medications accordingly. They will definitely be at risk of having infections, especially in sickle cell disease, because of the splenic dysfunction. Now, once that phase is over, then long-term complications or long-term follow-up is equally important, because as I highlighted in my presentation also, the objective here is not just to give them a sickle-free life. The objective is to give them a good quality of life, which includes sort of their going back to the school or college or society in as normal possible way as it can be. So again, post-transplant, the strategies remain the same. Your endocrine evaluation, especially in sickle cell disease, if there has been a end organ damage earlier, that needs to be addressed or watched carefully. At times, what happens is that if there is a borderline end organ damage, say for in some patients where there was a not end-stage renal disease, but sickle nephropathy, which was around grade 2 to grade 3. In majority of the patients, it reverses, but in some of the patients, it unfortunately progresses, and these are the patients which will need further supportive care. So I think it depends more on the end organ damage. We need to categorize which phase of transplant is the patient in, what were the pre-existing challenges of that particular patient, and all these put together, we need to decide our follow-up strategies.
Yeah, I would like to specifically ask Dr. Atish, would you like to give them, longer penicillin prophylaxis after transplant if they have, a spleen dysfunction? Do you evaluate a spleen dysfunction pre-transplant? And if they have severe dysfunction, would you like to give them penicillin prophylaxis longer? Because we have done a study in our hospital, we had done splenic scintigraphy, and we have found many of the patients has good preserved function, and few patient has absolutely no splenic function by scintigraphy. So how do you go with this splenic dysfunction? This is important because you may be transplanting and the patient later end up in severe shock in remote area and sepsis.
So Sunil, for first 3 months, usually like if they have some or other issues, we post transplant we are talking about, they receive some or other type of antibiotics, and we know that the literature suggests that after 1 year of transplant, many patients have there is like if you check by scintigraphy, there is a return of splenic function, and I think if there are good neutrophils and we keep checking as Dr. Gaurav already told you, like day 100, like 3 months, 6 months, we keep on checking their immunoglobulin profile and lymphocyte subset analysis. Good functional neutrophils are there usually after 2 to 3 months of transplant. So my court, or usually like you, I think Dr. Gaurav also, mostly we do not use penicillin prophylaxis post transplant to that extent, like the way we use like early less than 5 years of age. I think anything Dr. Gaurav can add to it.
Gaurav,
I
I had a
think
question for you.
yes, sir.
Dr. Gaurav,
Yes,
when
sir.
do you revaccinate them in sickle cell?
Sir, all the patients on
But
revaccination.
what time period?
Sir,
Same as
after
other
all the
transplants?
patients go on revaccination roughly after 1 year. But we follow our immune reconstitution parameters, and in 99% patients, the immune reconstitution by day 365 is very good. So they should not be on steroids. They should not be on routine immunosuppressive agents, and with good immune reconstitution, and that's the time we start revaccination.
So I think that this is the sepsis part I would like because many of these patients may have persistent dysfunction. So I think monitoring splenic function post transplant might be a good initiative you may look upon. I maybe in your practice also. So with this, I would like to put some my views. So this is what we do. Like I do in my center, AIMS Raipur. We are also very high load of sickle cell disease. We baselinely once we diagnose the patient, we do baseline workup, and we start then them on penicillin, hydroxyurea 10 to 15 mg per kg per day, oral penicillin less than 5 years, folic acid and vaccinations. Then we look at their every 6 weeks, we monitor them, evaluate for baseline hematological tolerance, adherence, and side effects also. We monitor their frequency of acute clinical events like vaso-occlusive crisis, ACS, splenic sequestration, transfusion records, and we keep on monitoring their chronic organ dysfunctions depending upon the age and the monitoring frequency. Then we increase the dose only if they tolerate well, compliance is good, and if they have some basal persistent frequency, and if the any organ dysfunction start set in, and we to 30 around 30 mg per kg per day, some children may not need this dose. Sometimes we just, use their best stable dose, which may be 20, which may be 15, or it may be 25 years. But, we keep on monitoring their compliance and disease progression based upon their clinical event and chronic organ dysfunctions. So this is what we monitor them, routinely, particularly transcranial Doppler, ophthalmology evaluation for retinopathy, renal parameter like urine microglobulin, creatinine, EGFR. 2D we do once or twice, once or 2 years, and then hepatic 6 monthly. Iron oral if they are transplant dependent. Growth monitoring and neurocognitive monitoring keep on doing. So this is our escalation pathway. We just start on hydroxyurea. Many times I add zinc, and some patients have been put on L-glutam because there are no other drugs available. PK activity is still coming up. We don't have data much. Few patients need only, I think, 10%, less than 10% need chronic transplant therapy. Many of them actually need an extended transfusion, and many of patients actually need a transplant. Good number of patients actually. So this is, we identify severe phenotype, donor search, fitness, and we counsel them for a curative therapy. So this is the paper already, I think, explained. So basically this paper which I was talking about provides the strong evidence of supporting efficacy of HLA identical sibling transplant in both children and adult with sickle cell disease. So we have to advocate the transplant for its sickle cell disease early as possible before the organ dysfunction set in. So that I think we have to change. I hopefully looking in the guidelines. I also request Dr. Yadav to include the clinic physicians or pediatric hematologists from the area where the sickle cell load is very high. So that may give a feedback to them. So this is the excellent and study by Dr. Gauria, Dr. Gaurav Kharia et al. And the group. So this has definitely put our transplant in sickle cell disease to the global map. And we can here we can see that the threshold age, particularly less than 10 years, has a very good outcome. And as age increases, the complications are more. So we need to have hub and spoke referral model also, because the transplants are concentrated in an area where there are no sickle cell disease, and transplant centers are actually less in those who are having a high load of sickle cell disease. The anytime patient reaching to that area may be difficult, so we need to screen early, secondary, provide optimal medical management and refer them, and we need to help them early. So this is our my slide. So we must transition to clinical narrative from who qualify for a standard transplant to broader unbiased evaluation of who need curative therapy. So doing so bypasses HLA donor availability barriers and implement modern genetic intervention equitably. So that's it. And these are references apart from some of the references I put in the earlier slides. And I thank you, my panelists, Dr. Gaurav, Dr. Atish, Dr. Ankit, and Dr. Saili, for fantastic inputs and contributions on these topics. Thank you for your fantastic views.
Thank you.
Over to you, Dr. Ajita.
Yeah. Thank you, Dr. Sunil, for moderating this wonderful
Yes, Dr.
session and covering all the topics from challenges on the practical basis to the extent of the gene therapy. And Dr. Gaurav and Dr. Atish for enlightening us with the latest development in the field of sickle cell disease. And I think majority of the questions mentioned in the chat box are answered. So I think as we are late, we'll end the session here.
Is there any questions we need to answer now?
Yeah, no, all of them are answered.
Almost answered. Okay, great.
Yes. thank you once again to all the faculties. And next month we'll skip the session because of the midterm FOCON. So from August onwards, we'll start the national webinar again. Thank you.
Thank you
Thank
so
you all.
much.
Thank you, organizer, Dr. Gaurav, Dr. Ajita, Dr. Yadav, and fantastic PHO team.
Thank you so much. Thank
Thank
you.
you so much, everyone.
Have a great evening. Bye-bye. Good night.
Bye.
Thank you, sir.